Dr. Kanika, you'll be the slides for the introduction.
We are live, please.
Yeah. Dr. Kanika, you can start. We are live. Dr. Kanika, you're there?
Sir, I'm here. I'm here, sir.
You can start. We are live.
I'll share my screen. Dr. Kritika, are you there? Oh, she must have
I
logged
think
out.
she's logged off, yes.
Yeah. Okay. Good evening, everyone. Today we've gathered for the episode 407 and the current cataract module number 20, cataract module with episode 21. And we have the great Major General Professor Dr. Sagarika Patyal from Delhi, who will be talking about combined cataract and filtering surgery. Our esteemed moderator, Dr. Amit Pandey, sir. It is my privilege to introduce sir. He's one of the young achievers and a very accomplished surgeon, one of the few people who are practicing MIGS in India and even has many accolades such as being the first surgeon to implant an eye stent in India. Sir, over to you for our chairperson's introduction.
Yeah, thank you, Dr. Kanika. It gives me immense pleasure again to introduce the chairperson for today, Professor Kamaljeet. Sir has done his MBBS and MS from MLN Medical College, Prayagraj, and he has been the HOD of MLN Medical College. He was the past president of IRSI UPSOS and has served as an editor in various prestigious journals. Currently, sir is the head of department at United Institute of Medical Sciences and a senior consultant at Center for Sight Prayagraj. Sir, the chief editor of Ophthalmology and Allied Sciences, has been awarded as the WHO Fellowship in Medical Retina, USA, and fellowships from Wills Eye Hospital, Philadelphia, and Massachusetts Eye and Ear Infirmary in Boston. He has published many books in ophthalmology, the most popular being Small Incision Cataract Surgery. Sir is an academician par excellence and a guest speaker at international repute. So I welcome Professor Kamaljeet sir and thank him for his time that he has given to iFocus. It's an privilege for me to introduce the speaker for today, Major General Dr. Sagarika Patyal, ma'am. Ma'am has done her MBBS from Calcutta Medical College, DO and MS from Army Hospital, Delhi, glaucoma training from RP Center Ames, and ma'am has been a gold medalist. She has received the Frank Connors Silver Casket for standing first in surgery in Calcutta University. Currently, ma'am is serving as a senior consultant at Center for Sight, New Delhi, and we're very lucky to have her. She has served as an assistant chief of integrated defense staff at Army headquarters, Delhi, HOD of ophthalmology at Army Hospital and at Army Base Hospital in Delhi, professor at AFMC Pune as well. It's a unique CV. Ma'am is the only lady officer to have commanded the world's highest general hospital in Leh. That's at 11,400 feet, where she was instrumental in establishing the telemedicine nodes in high altitude Siachen. That is one of the highest areas of our country to help soldiers stationed in the highest battleground in the world. Received the Vishisht Seva Medal in 2016, Sena Medal in 2014, Chief of Army Staff Commendation in 2004 as well as 2011, among other prestigious awards. She's active in research, has more than 49 publications, both in international and national journals, has written chapters in books and edited a book titled Resolving Dilemmas in Perimetry. She is recognized as a supervisor to guide PG and diploma students, undergraduate, postgraduate teacher, and examiners. And she has also served as an MCI inspector for MBBS, DNB, national faculty in glaucoma, and faculty in DOS PG teaching programs as well. She has also served as a referee for the MJAFI Index Journal and reviewer in Journal of Clinical Ophthalmology and Research, as well as Delhi Journal of Ophthalmology. So I welcome ma'am, and with sir's permission, we can start.
Yes, please go ahead.
Thank you,
It's
sir.
nice to have Dr. Sagarika here. And as you all know, she's a wonderful teacher and we are waiting for her lecture. Please go ahead, ma'am.
Thank you, sir. I'll start my slide share once the slides are off now. You'll stop sharing. Kanika?
Yes, ma'am. Please go ahead, ma'am. I've stopped sharing.
Okay, thank you. So first of all, thank you so much for the kind introduction. And Professor Kamaljeet, we are very grateful to you because to have such a huge academician as you chairing the session, it's a great privilege for me. It's also a privilege to have such wonderful youngsters like Amit Pandey, Kanika, and Krutika here to help me out. And I hope to convey some things which we are doing on a regular basis, and that is cataract with filtering surgery. You know, I've always wondered why it is called filtering surgery. And I think by the time we finish the entire presentation, we will understand why we call it filtering surgery. You know, cataract and glaucoma, they are practically found together. They coexist, just like the trees and the birds on this tree. The red ones and the blue ones, they're coexisting. They both affect the elderly. That's the reason why they coexist. Now, this coexistence might be either primary or maybe secondary. What do you mean by secondary? It means, let's say, the lens has become phacomorphic. It has become phacolytic. Or let's say there has been cataract after glaucoma surgery or anti-glaucoma drug-induced cataract iatrogenic. Therefore, we realize that both these diseases may coexist and we have to look after each one. So all of us know that we can do cataract also together. We can do cataract separately. We can do also glaucoma separately. Then why do we have to go in for these combined surgeries? Let's look at the advantages. See, they reduce surgical trauma. You're taking the patient once and at one go, you are able to do both the surgeries. For the patient, it means a much faster visual and functional recovery. Now, because phacoemulsification techniques have developed in such a wonderful way, we all know that once we do a good phaco, our pressures are going to reduce. We've got wonderful foldable lenses which can be implanted in the bag. We have got also immense improvements in glaucoma surgical techniques. Why is all this so important? Because of just one goal. We want safer surgery, more efficient combined surgery. So with developments which have taken place in both these surgical techniques, therefore, we find that our surgical results are much better. Now, when we do cataract surgery, we all know we give acetazolamide postoperatively. Why do we do that? Because we know that there's going to be a postoperative spike of intraocular pressure. Now, if a person has glaucoma and that patient has a spike, what's going to happen? Obviously, the optic nerve is going to get more damaged. Therefore, it is better to do combined surgery, as has been explained so beautifully by Shingleton et al. In 2007, so that IOP rise can be prohibited or stopped. Now, suppose we have done, let's say, for example, a trabeculectomy. Now, we all know that TRAB, unfortunately, does induce a lot of cataract formation. Now, we do a cataract surgery over there. What are we doing? We might compromise the functioning of the filtering bleb. So what are the indications of this combined surgery? You've got a visually significant cataract. Along with that, that means just a clear lens you're not going to remove. You've got a visually significant cataract, plus you've got advanced glaucoma. And that advanced glaucoma, it may also not be very advanced, but it is uncontrolled. And you've given multiple medications, and we find that the pressures are not under control. Mind you, that these multiple medications have their own problems. Along with that, we all know, moment a person has multiple medications, there's poor compliance, or let's say non-compliance. Patient is unable to come up for frequent follow-ups. Patient lives in a remote village. Many of our patients, we know they come from remote areas. They're not able to come for follow-up. What do you do? They're not able to get their medicines. What do you do then? In that case, combined surgery is the answer. Patients are intolerant to medicines. So many allergies. We just think about brimonidine. So many other drugs also. In fact, I've seen even Dorzox causing so much of allergic reactions. Patient cannot afford it. One of the most biggest things, patient can't afford it. So where separate and sequential surgeries cannot be performed, patient is a high-risk case. He's got multiple systemic comorbidities, a kidney problem, a heart problem, some kind of blood thinners he is on, some cardiac problem. In that case, it is better that you do two surgeries together, so at least you look after the patient well. So what are the surgical options in this case? One is, so that means you've got a cataract and you've got a glaucoma. You can do a combined surgery, or you can do cataract surgery, or you can do glaucoma surgery. It depends upon, of course, the amount of visual impairment. What is your target intraocular pressure? I'm not going to further explain about targets, but definitely target means that we want, if you have advanced glaucomas, we want that pressure by which the amount of glaucomatous damage also decreases. Then what is the stage of glaucoma? What is the compliance, age of the patient, life expectancy? That's extremely important. Suppose you've got a young person, you know his life expectancy is huge. You want definitely something that is going to work. And what type of glaucoma is present. So what we want is basically maximize the benefits and minimize all the risks to the eye. I've got a very good empirical guidelines from P.R. Bhagat et al. This is, of course, in a case where she's talked about small incision cataract surgery and glaucoma. But let's just have a look at it. It's a beautiful slide, and I just loved it. And I thought, yes, I must share it with the others. So you've got a visually significant cataract, and you've got a glaucoma. Now, this glaucoma is well controlled. It's got, let's say, mild to moderate damage. Then in that case, you go ahead and do just a cataract surgery. Suppose you've got advanced damage, then in that case also she is recommending that you go ahead and do, suppose you've got a significant cataract, borderline glaucoma has been controlled with mild damage or moderate damage, then go ahead and do a small incision, that means a cataract surgery with a trabeculectomy. And of course, if you have a glaucoma which is totally uncontrolled, then you must do a glaucoma surgery. Now, another thing which is very important for all of us is that multiple medications we know are required to control intraocular pressure. These medications, the usage is limited by what all? Allergies, medical contraindications, patient to some other medication we can't give. Let's say, for example, the patient who's got asthma, you can't give it. You can't give timolol and any of the beta blockers. Then the patient has got only one eye. He's unable to tolerate two separate procedures. There's angle closure category. Now look at all the pictures I have shown. These are the type of typical adverse reactions that a patient has. Now suppose you're going to do surgery in such a patient. What is your checklist? So you first stage the glaucoma in both the eyes, visual fields, optic nerve, head damage. You must do a gonioscopy. That's imperative. It's imperative for you to do it. Review all the medications the patient is on. Can we change something? Is it possible? That means you're not just jumping at surgery. You're looking at the patient whether you can do something in order to prevent the surgery also. Grade your cataract. It has to be visually significant cataract. And complete your ocular examination to look for any other risk factors. Along with that, please don't forget to look at the corneal endothelial status. And the specular microscopy is extreme importance over here. And I would like you all to know that endothelial cell loss occurs after glaucoma also, both because of medications and also after glaucoma surgeries because of the anti-proliferative medications that we use both for filtration surgery as well as for aqueous shunt implantation. And the endothelial loss in glaucoma disease is, and because also of the treatment, not only because of the disease, but also because of the preservatives in the glaucoma medicines that are there. So our endothelial cells, when we are doing a combined surgery, is extreme importance to us because we have to prognosticate to the patient that you have got endothelial cell damage and that the chances of your developing corneal edema are extremely high. For example, reduction of endothelial cells in a case of POAG is approximately 5.47% because of the direct damage, elevated intraocular pressure, cytotoxic effects of ocular hypotensive drugs, and impaired endothelial metabolism because of disruptive aqueous humor circulation. Also, you can have just about congenital endothelial abnormalities. So, when we are doing surgery on such a patient, there's one surgical pearl that we must remember: use a dispersive viscoelastic by the means of the soft shell technique, which will prevent further damage to the endothelium. What is the preoperative preparation? You must give antibiotic prophylaxis, just like we do practically in all our cataract patients or our glaucoma patients, 3 days prior to surgery. And there's no need to stop. There are many people who believe that, yes, you must stop. Even I used to do that, but we realized that no, it does not matter. Go ahead and continue the patient on the prostaglandin analogs, unless, of course, the eye is injected or it's inflamed. Now, we must try to control medications or avoid medications which have preservatives, especially benzalkonium chloride, because these are toxic to the conjunctiva. The eye is highly inflamed. Stop the anticoagulants, because the moment you are going to use the anticoagulants, you're going to have problems in the form of bleeding, excessive amount of bleeding. So please don't use it. And in case you find, because you see so many medications have been used with the patient, there will be significant ocular inflammation. Give topical steroids. It may be just a low strength loteprednol. Even that will help the patient a lot. There are many risk factors of such patients. For example, you might have a small meiotic pupil. You might have also things like a PEX glaucoma with very weak zonules. All these things have to be kept in mind. You might have a crowded iris. You might have, let's say, a post-iridotomy has been done, and there are weak zonules along with that. Now, there can be various causes of poor pupillary dilatation. Now, therefore, you are doing 2 things, cataract and glaucoma. And here, because of chronic use of miotics, these, of course, now is much lesser in these days because pilocarpine is not used to that an extent, although Iotim Plus has definitely made its foray in very nicely into the world of glaucoma. Chronic inflammation can be there, causing synechia formation, chronic angle closure, and also prior trauma. These things must be looked at before you take up the patient for surgery. Your planning of your surgery will go on what you have seen initially for the patient. Has the patient undergone prior laser procedures? Is there pseudo exfoliation? Because with pseudo exfoliation come the other problems in a patient of glaucoma and also of cataract. Is there diabetes? And of course, is the patient on alpha-adrenergic receptor blockers? So you should, what is the management? Stop the miotics. Use intracameral. One important thing is preservative-free epinephrine. Use the cyclodialysis spatula or any other instrument to carefully break the synechia as well as the pupillary membranes. Sometimes you have to cut these membranes in order to allow the pupil to dilate, because mind you, you have to do safe cataract surgery along with that safe also glaucoma surgery. And you can do a lot of viscodilatation. These are very important points while you are looking at your patient preoperatively to plan your surgery. So you can also do sphincterotomies very comfortably. We all are very comfortable with the use of iris retractors, although many other mechanical devices are also available where people who are using them are comfortable with them, and that also can help us perform good surgeries. Now, we must have backup pupil expansion rings, capsule retention rings, because you can have pseudo exfoliations also. That is why it's very important. You must be ready with vitrectomy as well as tricot and also viscoat, because we need to have, remember, the soft shell technique is very, very important because the endothelium may be damaged. So once you have looked after all these conditions, your pre-operative planning of a patient with cataract and glaucoma is extremely important before you jump into surgery. What are the methods available to us? The commonest method as of now, because of the immense amount of improvements and technique which have taken place, is phaco-emulsification. And we want a posterior chamber in the bag implantation of the lens. That's the best form with trabeculectomy. And of course, we normally always use an anti-proliferative agent like mitomycin. The strength of mitomycin will depend upon the type of sclera that is available or the patient's refractive status of the eye. Then you can also do manual small incision cataract surgery with trabeculectomy with mitomycin. What is not done these days is extracapsular cataract surgery. But all of us who have been in the era of extracapsular cataract surgery, we know that it's a very important, we used to perform these surgeries, although we don't have videos now of this, but this was an excellent surgery in order to do this combined procedure, from where initially this name of combined procedure actually came. So let's look at phaco-trabeculectomy. What are the pros? It restores vision promptly because you're giving lens to the eye in place of the cataractus lens that is there. It is better, much better patient compliance. It's a single procedure, but the patient is on the table for a longer time. There can be an increased risk of complications, hyphema, uveitis, shallow anterior chamber, hypotony, of course, more intensive postoperative care. Now, in a phaco, let's say we look at a phaco-trabeculectomy versus a manual trabeculectomy. In a phaco, we are using a smaller incision. There is less inflammation, faster visual recovery, but the but is very important. You've got expensive equipment which you require in the OT. In a country like ours and many other developing countries, we must understand that cost is a very important factor. In a small manual small incision cataract surgery, on the other hand, associated with the trabeculectomy, this is a larger but a self-sealing incision. You've got an extra incision you might require for those people who use the anterior chamber maintainer. Therefore I don't require it, but many people are there who use it routinely. There's less instrument dependence. What we are using for normal cataract surgery, we are comfortable doing also a trab with it. It's very cost effective, much lesser surgical time, can be used. This is a very important thing, can be used in rural and low cost settings for providing quality surgical outcomes. Of course, there is increased inflammation, slower visual recovery, and with the bearing on the bleb survival in combined surgery. So now let's have a look at it. So phaco-trab again can be done by again some methods. So what is the first method? First method is one site. That means if you can see my cursor out here, this is the first site where we have made a trab. First of all, the lamellar flap. After raising the flap and doing the cautery, raising the flap, then after that putting in the mitomycin pledgelets, and then doing the cataract surgery through that itself. Once you do the cataract surgery, form the anterior chamber. After that, through the same pot, we are able to make the sclerostomy nice. The wound is very nicely made. And then, of course, we are able to close off the wound. And that completes the surgery for a superior phaco-emulsification with a trabeculectomy using only one site. So this is a very comfortable procedure, but we have found a little bit more inflammation because this is a personal opinion. We used to do it for many, many years earlier, but now we have stopped and we have gone on to the second approach, and that is the two-site. So let's have a look at this video. And as we are seeing the video, we'll come to know what we are doing out here. So first of all, of course, is the conjunctiva, which has been nicely cut after the cauterization. The cautery should never be just, rubbed onto the entire sclera because that's going to cause fibrosis. And then once you have made a nice flap and then we go ahead and make the flap. After that, we have now put, of course, the mitomycin. Then we go ahead and do a normal cataract surgery. And in this, once we have made an adequate sized this thing rhexis, then go ahead and do a good hydrodissection. Sorry, where have I? Here we are. Here. So I'm sorry again, I think I was trying to hurry it up, and so therefore I have messed it up. Okay, let's go ahead. And so now we have left the site where we were doing the started the trabeculectomy. And why do we make the trabeculectomy flap first? Because if your eye becomes soft, you can't make a good flap. That's very, very important. Now this, I'm sorry, I have gone to the next one. So I will go back to this first slide. Yes. So this is the temporal phacoemulsification with a superior trabeculectomy. And here we are doing the cataract extraction. And that's a simple, normal thing that we always do. I'll just go a little ahead. And please look at the golden ring that has been obtained. And then you do a normal phacoemulsification that I think you all are experts at. Very important, remove every bit of cortical tissue that is there. We do not want any kind of inflammation in the eye, which this cortical matter will cause. And then put your lens into the bag. Let it unfold over there. Ensure that it is there. Again, I've gone back. And I'm sorry, I think I'm messing it up. I'll just... I wanted to show some things. Let's see over here. Yes. So now that we have done this, after that, now we go on to we must close the wound. So you have removed the cataract. You have removed all the cortical matter very, very nicely. And after that, you must close the wounds so that now you have a tight chamber. If you don't have a tight chamber, obviously you cannot do the sclerostomy. So now let's have a look. So now I have already done the sclerostomy, and if you can notice that, there is one small little suture here. This is a very important thing that you must notice. By chance, if you have made a small cut in the lamellar flap, ensure that you have sutured it. After that, over here, I'm putting in the releasable sutures. I put Wilson's releasable sutures in not practically, I do it in all cases unless I'm not being able to do it. And once that is done, then of course we give the subconjunctival. And very, very important is you must not forget to put the conjunctiva properly. And this is of course how we are tying the releasable suture. I'm sorry, my this thing has been jumping a little, and therefore I would have loved to say it in a little slightly better fashion. Now let's come down to another Phaco-trab, which is an interesting one. And this is again a 2-site one with a mitomycin that is 2 milligram per ml in a case of iridoscheisis. I've shown a figure in the figures by the side for the listeners that look, this is how a scheisis looks like, where the iris has been split into 2 parts, anterior and posterior. Most of the anterior part is lost, and then there's merely fibers. Now let's have a look at this. It's a short video given to me by this my case, but it has been edited very nicely by my friend Kanika. And you see that again, you're making the same thing. That is, you made a good flap. Now, when you are making this flap, please ensure it is not a thin flap, and that you are able to make out, the bottom, at the bottom of the flap, you are able to make out the fine uveal tissue, light brown tissue. That means, that depth is absolutely correct. Now I am doing the phaco by another pot. Very simple is what's the problem? The problem is that this iris is now coming into my pot. So in a case of iridoscheisis, now see, every time you try to pull, so now what am I trying to do? I keep on and on trying to protect my whatever iris tissue I have, but this becomes extremely difficult. And then again, this iris, because it's absolutely flimsy, floppy, it'll keep coming out, and therefore you have to use certain other techniques in order to remove the cataract. Once you've removed the cataract, once again, the thing about removing the cortical matter very thoroughly so that you do not have any inflammation. After that, inject your lens properly into the bag, and then here, lens is being injected. And then, of course, you go ahead and do not forget to put a good suture. And then, of course, I like to cut my sclerostomy by means of Vanna scissors. And then, of course, suture the wound. Don't forget to suture the conjunctiva very, very thoroughly. That's very important because that's where the bleb is going to form. And this bleb through which the fluid is going to filter out is known as the filtering bleb. Now, another case of high myopia. In a high myopia, things become slightly different. You are doing a phaco-trab with mitomycin, but here the mitomycin content is going to be, the strength is going to be much lesser, because if it's a thin, the high myopes have very thin scleras. Therefore, the amount of absorption of your mitomycin will cause a lot of hypotony. We have seen eyes being lost because of use of excessive amount or the normal amount of mitomycin and being used for the normal time. Let's say, for example, you are using 0.2 milligram per ml and using it for 3 minutes, decrease the amount. And I'll just show you again a brief this thing of this particular case. We have already, I like to go by the, I don't use the corneal suture, traction suture. I prefer to use the other suture. So again, I'll just fast forward it a little bit because this is something that we have already discussed, how to cut the conjunctiva, how to do various other things. Just don't forget, please do not cauterize so badly so as to make do complete fibrosis. And you can use various types. You can make a rectangular flap also. You can also, by the way, not just do a fornix based, you can also do a limbal based. All of them work very, very well. So long as you know what are the pitfalls of each surgery. Don't forget to locate the gray area very thoroughly. And again, when you are putting in your mitomycin, here I've put the mitomycin just for 1 minute and a very thorough wash has been done. And now we just go to the end of the surgery because the rest of the surgery, I think we all have seen. So here, now after I have put my releasable sutures, now I'm going to put something which we normally don't put, and that is an amniotic membrane. This is the releasable sutures which are being put on the two sides of the wound. And after that, here is the amniotic membrane. Now, this is put in cases of high myopia also, so as to prevent, because see, we have used less of mitomycin, there's a chances that our bleb is going to fail. So therefore, in order to prevent that, we can put this AMT also, which is why I have shown this particular type, this particular surgery. So what are the advantages of one side, both or two sides? Both of them work extremely well according to various studies which have been done in 2005 and 2011. So no problem at all. And we must give peribulbar anesthesia. Please avoid any kind of pressurizing techniques in cases of advanced glaucoma. I put a brittle suture. You can use a corneal suture, whatever you are comfortable with. Do a superior conjunctival peritomy, gentle cautery, which I have repeatedly talked about. You can use any type of flap, whether it is triangular flap or it is a rectangular flap. Now, I'm not going to go into this very again because we have repeated all of it. But we must remember that when we are doing a phacoemulsification, be very careful that your increased infusion bottle height to prevent anterior chamber collapse. That we don't want. Remember, the moment your chamber collapses, you're going to have a lot of hypotony. Then visco, thorough cortical cleanup. The rest of it I have already talked about. And you can use either vical suture or you can use 10-0 nylon also. And don't forget to give a subconjunctival. Of postoperative regimen, don't forget to give topical steroids with antibiotics. Atropine is an absolute must, and artificial tears. And you must do the postoperative evaluation by looking at the bleb, height of the bleb, presence, absence of microcysts, aqueous leak, flap sutures, of course, intraocular pressure. What our chairperson is an expert is, that is the small incision cataract surgery. You can use the single site, or you can also use a double site. In the single site, the type of incision that is made in cases of a phaco, in cases of a small incision cataract surgery with a trab, as I have shown in the diagrams. These are not my own. This has been taken from a particular journal. Again, do a small paracentesis. If you want an AC maintainer, it's optional. Form the anterior chamber, do a proper hydrodissection, prolapse the nucleus into anterior chamber, do a cortical wash the same way as we do a normal small incision cataract surgery. Close the wounds very thoroughly. Now I will again show you. There are again two approaches to it. Either it is a single site or you can have a double site. So in a single site, what do? You are doing a small incision cataract surgery. This is a very small little video. So let's have a look at it. Now, if you look at the cataract, it's a highly significant cataract. Along with that, you also notice one more thing, and that is it is fibrosed. Now, look at the way the incision is made. See, it's a triangular incision, and the rest of it, the incision, so I think we teach the DNB students also how to make this. And after that, again, you make your flap very nicely, very comfortably. Always when you're making the flap, don't make a thin flap. It's going to tear in your hands. It'll come off in your hands if you're not careful. So you must make a flap enough that and then of course you make your wings. You enter the same way as you are doing a normal small incision cataract surgery. So both of them, and don't make them into too uneven. That means incision in one side is in one plane and the other in another plane. It should be uniplanar only. And the same wriggling movements which are used in order to make this go as anterior as is possible. And then after that, enter the anterior chamber. I like to put in my air and the Blurex, stain it, make a nice big capsulorhexis. And after that, we have to remove the cataract by means of various techniques, which we are very well aware of. And once that is done, after that, we have to go ahead and let's just go through it once here. Now we have removed it, and now we are trying to take out the cataract. And I think this is well known to everybody. But what I would like to show you is the thing after that. Again, don't forget that you have to put the lens in the bag. So put the lens properly into the bag. Don't let it come out. Remove the cortical matter, which you can see a large amount is there. So I have removed it later on. After that, now you have to do the suturing. This suturing of the wound is extremely important because now it's an open wound. So you can't do anything with an open wound. So you have to make your sclerostomy. So now you can see the blue area. And then after that, I like to do it with the help of my keratomes. And once you do that, and then after that, you remove a nice big patch of your sclerostomy. Here you can see it very clearly. A little too much of cutting I feel I have done. Probably the blade was not too sharp, but you must use as sharp a blade as is possible. And once you have done that, then after that, once again, you put your releasable sutures. You must make a full, complete iridectomy. Whenever you do the iridectomy, it should be as big as the base of your sclerostomy. That is very important. Otherwise, this will stick on to the sclerostomy and completely cover it up. And then you must always see, once you've done the iridectomy, whether it's a complete iridectomy. That means both layers are present or not, or you've just done a partial one. So that's very important again. And then after that, of course, you must suture your wound very thoroughly, and the same way as we close off of a normal trabeculectomy. And not to forget what is very important for all of us, and that is close your conjunctiva to the best of your ability, because that is where your filtering bleb is going to form. And in those cases where we are always doing a fornix-based flap, remember that fornix-based flap, we are going to have a little bit of a leaky wound. So the stronger, better method by which you are going to tie this, the conjunctiva, you remember that you'll get a good bleb, and that will also function very, very well. So we'll go to the next. Now this is again a small incision cataract surgery with mitomycin. The mitomycin I had not shown over there. Probably in the editing, it's probably gone off. So again, it's the same thing, that once you have nicely made it, then again, your cautery, never excessive cautery. I cannot repeat it sufficient number of times. And after that, you put in your mitomycin. Mitomycin these days can be even given in the subconjunctival way but you can also do it the way we normally do. And that is, once you have entered the anterior chamber, you never put in mitomycin, you'll go directly. There's one thing for the youngsters that I would like to repeatedly say, that you must put the mitomycin before you have entered the anterior chamber for whatever reason. So once you have put it, you must count the number of cotton pledgelets that you have put, or the varicose sponges that you have put, and after that wash it. And I always say wash it with minimum of 30 ml of fluid, and then the rest of it is the same. So you can have a two-site surgery also. That's a temporal manual small incision cataract surgery and a trabeculectomy superiorly. The advantages are that there's less manipulation of sclera and conjunctiva, less risk of excessive coagulation that can cause significant tissue shrinkage, and unpredictable astigmatism can occur because of that, difficult closure, less metabolite and anti-metabolite entering the anterior chamber, and less chances of postoperative trabeculectomy, suture modification affecting the cataract incision. Now, advantages of manual small incision, that is lower average surgical time, lower cost, lower equipment, and it is also very suitable for dense cataracts where the posterior capsule cannot be seen, for hard cataracts where phacodonesis is present, for the inexperienced surgeons considering the less postoperative complications amongst them. So, if you consider actually the postoperative complications, there are hardly any postoperative differences. Phaco group, there's statistically less astigmatism. Combined surgery has lower risk of complications than the two-stage procedures. And disadvantages are longer time. There's incidence of failure is high, less efficacious than sequential surgery. Common complications, of course, can be there, and bleb-related complications actually can occur in any condition, whether it is single. Now, this is one surgery which I know most people would not do, but it is always important to learn. And this has been taken from the YouTube because I didn't have any of my own. Please have a look as to this is how an ECC PCIOL is being done with I just want you to have a look at the beautiful incision that is made, and it's the same thing. It's only that in a small incision cataract surgery, we go behind into the sclera, and this is right on to the incision is made onto the on the limbus. Otherwise, the basic surgical steps are practically the same, and it's some beautiful surgery which I feel we should not lose it to time just because of developments have taken place, because you never know where you require what. So this is the last type of combined surgery that I'd like you to have a look at. And this is how the sclerostomy is being done. And the rest of the surgery, of course, is the same. So a combined procedure is actually not effective as a trabeculectomy alone. Let me be honest about it. Adding cataract surgery to a planned trabeculectomy appears to counteract the IOP lowering effect of trabeculectomy by about, say, 2 to 4 millimeters. This is not what I have said, but somebody else has said. So when IOP is of paramount importance, and this is something of a take-home message, that it's better to separate the two of them and separate the trab and separate the cataract. But there are many conditions where you can't help it. You have to do it. And according to ages, patients that did not progress had a mean IOP of 12 millimeter mercury by this procedure. And a very, very low IOP is sometimes required to maintain visual function in advanced glaucoma over a long period of time. Sometimes we are not able to achieve this kind of low pressures in case we are doing combined surgeries. So I hope I have enough time to answer any questions. If I'm able to, I would welcome them. And I would like our moderator and our chairperson also to join me in case I'm unable to answer any questions. And if I'm not able to also, I would love to come back and again answer those questions. So Phaco-trab, or let's say a small incision, manual small incision cataract surgery with a trabeculectomy, when they coexist in a person, which it very commonly does, we should know how to do the surgeries and the various problems that can arise from it. We should be able to look after the complications that occur. Thank you so much for a patient hearing.
Thank you so much, ma'am.
excellent as always. Such a detailed presentation with brilliant videos, and of course the way you teach is always it's always very impressive. So thank you for the lecture. I would like our chairperson to now give his comments. Sir.
It was a very nice lecture. Dr. Sagarika has almost covered everything, starting from ECC IOL to SICS with glaucoma surgery and Phaco with your glaucoma surgery. So, TRAB and also how to put mitomycin in different kinds of scenarios. Dr. Sagarika, would you like to constrict the people before doing iridectomy that for the PGs?
I didn't get you, sir. I'm sorry, I couldn't get the question, sir.
What I'm saying is that before doing iridectomy, should we constrict the people with pilocarpine?
So, in case you want to, if you find that, the pupil is large, then it is nice. Yeah. But we have to remember that pilocarpine can cause immense amount of inflammation too. Therefore, after doing the surgery, it's better to wash it off.
Yes. So that was the only question. And please just tell them again about how to stitch the conjunctiva.
Yes. Thank you so much, because that's something that is so important. So suppose, for example, we are doing surgery with it is a fornix-based one. We know it's going to be a leaky bleb. And everything is dependent upon that bleb. Therefore, once you have taken, now there are 3-4 methods which I obviously could not put into this. One is take the conjunctiva on the 2 sides, tie tightly by means of sutures. I use 10-0 monofilament polyamide nylon. Other people also use 8-0 Vicryl. No harm, you can use any one. Only I feel that Vicryl pinches a little. And the second thing is nylon. I like to keep the threads, the ends a little long so that they don't poke the patient. Now that's one. Second is methods which have been taught to us by our teachers. What are they? That is, you make small incisions on the cornea, then take a bite from the conjunctiva, go on to those bites in the superficial part of the cornea, and just like mattress, you must suture it so that it becomes absolutely tight, and now it becomes almost like it is leak-proof. So that is one other method also by which you can suture the wounds. And I do another method also, that instead of putting just 2 sutures on the 2 sides, I also put a central suture if I find that the conjunctiva is not properly adherent onto the cornea. Then I put a nice big suture in the center, but try to ensure that the suture knot that is there, that's not poking and hurting the patient. So there are 3-4 methods by which you can do it. The other thing, suppose, let's say, now this is, I'm talking about a fornix-based flap. Suppose, let's say you are doing a limbal-based flap. In that case, you don't have much of worry. Actually, you're just going behind, and then you're weaving it through, to quote Dr. Ramanji Sihuta, who's been my teacher, she used to just weave the entire conjunctiva very closely with, again, she used to use steno nylon, and then see to it that the wound was beautifully watertight. So that way you are ensuring that your bleb will fall. Your basic thing is you want your bleb to fall.
And one thing more, ma'am, how big should be the opening that you make in the limbus?
So if a slide, it's 2 to 3 millimeters, sir. That is the amount that we normally want. Now, suppose let's say, for example, I don't use the Kelly sponge. Lots of people use Kelly sponge. So 2 punches of Kelly sponge does the job. But I like to make it a little bigger. Now, what is the advantage of having a bigger one? See, I'm going to put my 2 releasable sutures, that's a Wilson sutures on the sides. Anyway, it comes down to approximately, let's say 2 to 3 millimeters only. And then the advantage I have that I can remove my releasable sutures whenever I want. And that is within 3 weeks, because I'm monitoring the patient at much more frequent intervals because I want the bleb to survive. And if you tell the patient, okay, come after 2 weeks, then it's of no use. You've lost that golden opportunity. So that is why you can, normal amount is about, say, maybe, let's say 2 to 3 millimeters. But other than that, it is rather not 2 to 3, it's 2 by 3 millimeters. And then if you want, you can also, as I said, make a slightly bigger one, but put freezable so that actually it becomes that small.
One more question, ma'am. This is about how much topical steroids you
Sir,
put.
beg your pardon, sir?
How long do you put topical steroids?
Sir, it is, first of all, it is unlike the cataract surgery where I'm giving it for about, say, 5 to 6 weeks. Here I use it, minimum period will be 8 weeks. If I find there is more inflammation, I will give it for longer. Again, it depends upon my bleb. If I find that my bleb is not functioning well, I have got corkscrewing of blood vessels present on the, a lot more blood vessels on my bleb, I will like to put my steroids for much longer. So it depends totally on how you are seeing the patient, how much of inflammation is there, and how much of vascularity is there on the bleb. Based on that, you will give your topical steroids to the patient.
Thank you so much, ma'am. These are all my questions that I wanted to ask. Over to the convener.
A pleasure, sir. My pleasure, sir. My pleasure. I'm honored, sir.
I have a question, ma'am. Could you tell us something about the IOLs that we use in phaco-trabs? Some people, they tend to use toric lenses also with a combined phaco-trab. What are your comments on that?
Okay. I'm glad, Amit, you broached on a topic which is very important for us to understand, that when we are going to do a trap, there are going to be so many sutures. If there are going to be so many sutures, we have got to remember that we are creating an astigmatism. One thing which, as I said, it's very difficult to cover up every aspect. But when we are counseling a patient for phaco-trab or any of the combined surgeries, we have to tell the patient, look, your vision is not going to be initially the same as it was before. And why is that? Because we have put sutures. And those sutures, especially when you're putting releasable sutures, you have to wait, let the entire wound settle down. So how can you put a toric lens beforehand only? That toric lens is not going to. Plus also, we have to also understand that our anterior chamber is not very stable. Don't you agree with me, Amit? That it's not going to be too stable in a case of trab. So that is why I would avoid it.
Yeah, the chances of toric lens rotating also would be much higher.
Much higher.
Same point should be true for multifocal and trifocal lenses as well.
Yes,
definitely.
So there's one thing about this. We had a wonderful class with Kanika Bhardwaj at that time as a fellow, where we discussed that what is the best IOL in the case of, let's say, can we do flax? What is the best IOL? Can we put the premium lenses? In that case, it is a controversial topic. It's a controversial point because a person who has got loss of contrast sensitivity already, and now you're putting in a multifocal of whichever variety, whether it is a symphony, it's a, let's say, those extended depth of focus lenses or whatever type of lens, we are not going to get that kind of clear vision because the patient's optic nerve is already compromised.
If you're doing a trap, that means the patient is already, mostly the patient would be in an advanced glaucoma patient. So
it's better to put
a strict no for combined surgeries. Right. Another question that I have, ma'am, is angle closure glaucoma you have, and it's an uncontrolled glaucoma. You have decided to do a trap. So does your threshold for doing a cataract surgery in such a case is lower than a normal, say, for example, a normal cataract, which has come to you, a normal patient that has come with a cataract to you?
I have not got your question, Amit.
If we have an angle closure glaucoma, it's uncontrolled, and you decided that this patient needs a trap.
Okay.
Say, for example, the patient is 55 years old.
Yeah.
It's early nuclear sclerosis. So does your threshold of doing a cataract surgery?
No, I'm quite clear in this.
So you
See,
do only
I
a trab in such a case.
he is 55 years old. He's got a long life expectancy. I have to look at my patient first before I try to do a combined surgery. I will get my chance for doing cataract surgery later on also.
It's not about doing the cataract surgery itself, but
Other cataract. So the important thing is if he's just got a, let's say, a nuclear sclerosis, which is possible, and any person who's above the age of 50, especially in the Indian scenario, in that case, I'd prefer to do a trab alone. Get that patient's eye pressure under control properly. After that, anyway, once we do a trab, the cataract is going to mature, then we'll probably...
exactly, that's the point. We are going to do a cataract surgery, say, for example, 3 to 4 months after the trab, and the cataract surgery is bound to have some effect on your pleb as well. Especially in a case of angle closure where the AC is already very shallow.
Yes.
Don't you think knocking off the cataract would make more sense along with the trab?
You have a point there, Amit. I agree with you.
Because the cataract would become more and more difficult.
This question is so debatable, so controversial. It depends so much because you see, moment you do, let's say your cataract is also significantly thick and it is also attributing to the angle closure. In that case, definitely it's going to help me. But if I find that no, that the glaucomatous damage is so much that it is better to do a single surgery. See, it is a customized thing. Every patient has been looked at with a completely different eyes that, okay, you see that this patient has this problem. It's better to do this in this patient. You may be right, you may be wrong, but you will have to think individually for each patient. So if a person has got, let's say, very advanced glaucoma, very little cataract, I would then prefer to do a glaucoma surgery alone. And then, yes, maybe 5 months down the line, as you said, you have to anyway do it, but I'd prefer not to preempt it. I'd prefer to do it later. Maybe I'm, a little older, so that's why I'm conservative.
No, ma'am, you're absolutely right. Have you noticed with PG analogs, patients on PG analogs, because prostaglandins are known to cause intraoperative, not only inflammation, but also intraoperative progressive meiosis of the pupil. Do you find that difference in patients who are on PG analogs? I usually don't, but theoretically it is possible.
Amit, initially in, let's say, 2015, 16, 17, 18, when I was doing surgery, I used to stop the prostaglandin analogs. Every conference we went to, all the big speakers and all the people who were doing the surgery, they would say nothing happens. Just nothing happens. Professor Mrs. Sahota, she also said, they come from so far. I can't afford to wait. There's no place. So you go ahead and do it. You might have a little extra inflammation, but you're anyway giving steroids, no?
Right.
So it's looked after. So
even I don't stop now.
So I've stopped doing that. Earlier I used to, then I've stopped.
Ma'am, in combined surgeries, do you do the sclerostomy under air or under visco? After you have removed the cataract, put in the IOL, do you first do a visco wash and then make the sclerostomy, or do you think it's a good idea doing it under visco and then washing it off?
No, I don't put visco. I don't. What I do is, like, for example, I am doing a Phaco-trab. In that case, I have removed all the visco from the chamber. I put in air. Why do I put in air? Because I come to know where my Schwalbe's line is, where that air bubble exactly comes. And then seeing that air bubble, then I know that, okay, this is my gray area. Over here, I can make a good ostium. And so that gives me a very good anatomical idea that this is the place I must place my ostium.
Right, ma'am.
So
what I do in my Phaco-trabs is of course, we are putting the IOL under visco, and I don't remove the visco. I first make the sclerostomy because I don't want the antechamber too shallow at all, especially in angle closure cases where you have a risk of malignant glaucoma postoperatively. So I do it under visco. I put in the sutures, and before closing the conjunctiva, I do a wash. So what that does is it washes out the small iris fragments or the even the blood clots that are there on the edge of the stroma. It clears them off when we do an IA after we have sutured the sclera. So that's another advantage that I feel and works well. So
I totally agree. See, each thing has its own advantages. And as I said, that whatever works in your hand, I think that's important.
Right.
So what you are saying is something that even I would like to have a look at and try. But I like my air because it gives me a lot more anatomical confidence in my anatomy, that where I'm putting in my incision, and that should be absolutely correct.
Yeah, right. Because I use the Kelly sponge, so that
So that you
doesn't
don't
matter,
have that
yeah.
problem.
So
Correct.
you are making the incision that has to be very, very precise.
Yeah.
Great. So these days, many general ophthalmologists, so-called general ophthalmologists, who are seeing glaucoma patients as well, when they see a case with an advanced glaucoma and a cataract, they knock off the cataract and then send us the patient to do a trap. So what do you have to say to them? One, and
See, there's one is that I think, Amit, all of us must be very, very ethically correct. And that our patient is almost on his last legs where vision is concerned. I think that should be of concern to us as if that person was our own relative. And that's important. So that is why it is better that the ophthalmologist understands that knocking off the cataract will definitely lower the pressure, but only temporarily. That pressure in a case of advanced glaucoma will be inadequate, and that patient should have gone to a proper specialist who's probably doing this job on a regular basis, because then he has more experience.
True. And in such a case, when do you do the trap, ma'am? When you've got a case, say 1 month post Phaco, advanced glaucoma, who actually required a combined surgery. If it has come to you, then when do you do the trap?
I would prefer the eye to settle down. Give the patient sufficient amount of medication to keep the pressure low. Because if you do surgery too fast, then you are liable to get more inflammation. I would prefer the patient to entire eye to settle down comfortably, you see that there's no inflammation, and only then take up the patient. Maybe
at least 2 to 3 months.
Minimum.
Right. So we have, I think we have one question. Ma'am, what if while doing Phaco, you want to convert to SICS? Can we use the flap side during the combined surgery or go for a second side for SICS?
Well, I'd never thought of it. It's a very interesting question, really. So you have gone ahead. That means, first of all, your preoperative planning has not been too good. So you have to do a very thorough preoperative planning. That's why there were so many slides on preoperative planning for the patient. But nevertheless, you might, while doing surgery, suddenly land up into that kind of a problem. Then in that case, if you have already made the flap, from that area only, you can go ahead and do a see, I have shown the way the incisions are made. You can even see what is very important for us is that we should not just take, okay, we can't make a flap for a small incision cataract surgery. Go ahead and do an ECC, PCI.
Correct. That's where ECC would come in.
That's why we should never relegate ECC into the dustbin. That ECC is a technique that should be learned by all, because that's going to save us at the time when we need it most. So you can use that same trab and go ahead and use the same, the pots which you have used, put your incisions through that so that you don't create further incisions, because you can't roger your cornea and cause a problem for the cornea surgeons. Make your incisions through that and convert it into an ECC PCIOL. If you are able to do a small incision for that, then in that case, you can also just make your incision slightly behind onto the sclera and go ahead and do it. You'll be able to manage it fairly well with no problems.
Yeah, thank you, ma'am. Do you have any other questions, Dr. Kanika? Dr. Ishita, do we have any questions?
We have a few questions on the YouTube platform. First question for you, ma'am. What do you think about phaco and sclerectomy as a combined surgery? And she's also thanked you for your great presentation.
And thank you very much. See, now this is a very nice question, because you see, this was being practiced. Earlier days, we were doing deep sclerectomy, but deep sclerectomy only causes very little decrease in intraocular pressure. But suppose you combine it with a trabeculectomy, which I have not done, but I know that Dr. Ramanjeet and all have done in this place in RP Center. They have said, yes, pretty good results. Even Tanush Dada has done, and he also says pretty good results. But see, they don't do it in all cases. It's not that it is the thing you just take it and do. No. Suppose, for example, your trab has failed, then you are doing another trab. Then you can give it a better chance of success if you do a trab with deep sclerectomy.
Right. So, one question from my side, ma'am. If this is not a combined case per se, if a trab has failed, say, and you have tried needling and everything, what do you do next? Do you go in for a tube implantation, or do you do a second trab, even if there is space?
See, if one trab has failed, then I know that the chances of a tube are better, because the trab will fail because of fibrosis. Generally, look, generally a trab fails because of subconjunctival fibrosis. You have used your anti-proliferative agents despite that it has failed. Then I think the better chance for the eye would be a tube.
That's what I also do now. Initially, I used to do a second trab, but 4 or 5 cases failed miserably, and after that, I've stopped doing a second trab.
Yeah. No, all of us have gone through the same phase, my dear. The road is the same one that all of us walked on. And
Right.
after having our feet burnt and our wings curved, then we have decided, nah, Baba, no need. Because we have to look at the patients also. Poor things, you know, it's so difficult for them to keep coming along and getting surgery after surgery done.
There's another question for you, ma'am. Respected ma'am, how much scleral incision should go up to limbus or onto cornea?
I didn't get it. How much of scleral incision?
In the scleral flap, ma'am, till
No.
what area did the
Okay. Now this is, I'm sorry, as I said, you know, I could have just gone on and on. Moorfield's technique is a wonderful technique. And they talk about this very particularly. And if you all try it, it works. So when you're making an incision, then you don't make the two sides. Let's say, for example, you're making a triangular incision. Don't go take the triangular incision right up to the limbal area. So when, on the other hand, when you're dissecting it, then make circular motions so that your sides are more, that means you have not advanced onto the cornea so much on the sides as in the center. That means it's more like a semicircle. Your internal ostium is going to be over there, so that the flow is directed posteriorly. This was by Penco's safe Moorfield surgery, has described it very well. And all of us, I think, down the line have taken it up in order to improve our surgical and give safer surgery. Have I explained it? So what you are doing is when you're making a flap and you're going below the flap and you're going on to the cornea, don't make it straight. Make it semicircular so that the two sides are at a lesser distance in the cornea than the center, so that the fluid comes backwards.
So if I can clearly understand, ma'am, what you're trying to say, unlike what we do in a scleral tunnel incision where we open from end to end, instead of that, here in the flap, we don't want to open the edges. We just have to open the central area so that the fluid is directed posteriorly.
Absolutely.
That's a beautiful way of explaining, ma'am. And there's one more question. How to avoid subconj hemorrhage in block? I think it is very unrelated, but
No,
anyhow.
it doesn't matter. So how to avoid a subconjunctival hemorrhage when you're giving a block?
I think for a combined.
Which block?
Peribulbar, mostly I think they are talking about peribulbar block, because again that would
you have a subconjunctival hemorrhage, so what?
and that can, if it is in the superior area, that can cause
a little bit, yes, add a little bit. So you have got to see where the blood vessels are. So don't go at the point of the blood vessels as the first thing that you will. Pay attention to what you're doing. Generally, you will not. But sometimes you do get, you know, they're very friable blood vessels, especially in older people. You do rupture a couple of them, but you just wash it off. It'll go away. Nothing happens.
I think during peribulbar block, one thing that we can do, especially in cases of if you're doing a trab, avoid giving it superiorly. Give more inferiorly, so that even if you have a subconjunctival hemorrhage, it can be inferior.
Either inferiorly, or you can also go into the nasal area. That's a medial canthus area, canthal area. Over there also you can give a block. Or as my friend Kanika has taught me, go ahead and do a subtenous block. Yeah.
Yeah, ma'am. I was about to ask that question to you, that would a subtenon's block also serve the purpose in a combined surgery, or is it that we avoid and do only a peri?
I think, Kanika, all of us have learned it from each other, that a subtenon's block, giving the correct manner, you can do any type of surgery with it. So I have done cataract surgery and then gone ahead and then got the retinal surgeons to do this thing, ILM peeling for this thing, what is that? Lamellar, the macular hole. So all that can just be go with this block only. Nothing happens. It works very well.
Ma'am, one question that I would like to ask, in case of a primary failed trabeculectomy and there is also cataract present, for the second surgery, would you prefer a combined trab and cataract removal, or would you prefer going for any other modality, considering the first trab has failed?
See, this is again, as Amit asked. See, when we know, we have to understand why has the trab failed. Either it is that a bad surgeon like me has done a bad job, all right. Or a second thing is that there has been subconjunctival fibrosis. Both can be the causes, right? My sclerostomy is not good. I've done it posteriorly. I've not done anteriorly sufficiently. My ostium has got closed because of my, like the iris has got come along and just closed off my ostium. Then in that case, of course, you can even think of a second trab. But when you know that nothing like this, there is so much of subconjunctival fibrosis, then which is the commoner cause, then I would prefer to go in for a AGV with a cataract surgery, because you can do both of them very comfortably.
Yes, ma'am. There is another question, ma'am. Sclerostomy extension, whether it should be from the, how far should it be from the blue-white junction? Should it be anterior or posterior or exactly on the blue-white junction?
Blue-white junction. And then, as I said, if you can make out where the end of that is your Schwalbe's line. How will you come to know where's your Schwalbe's line? When you are doing a trap, let's say just plain trap. In that case, you're doing a paracentesis. After you've removed a little bit of your done a paracentesis, you've introduced air into the chamber. Once you've introduced the air, now we know where the edge of the air bubble is. That is where your Schwalbe's line is. So that is where you should anteriorly extend it to. So where first, for example, where the in the scleral area, you know that the fibers are in let's say a crisscross manner. That's not the area where you cross. You just go a little anterior to that, because that's where your entire limbal area for your trab is existing. So you have to begin from there. So don't begin at the area where the crisscrosses, begin at the blue junction, just the first indication of the blue line, let's say, and then go anteriorly up to the place where you have made, where you can see the edge of the bubble. So that's the extent that you must go in for. It's not very big, it's very small, but you have to identify those things on the patient's eye.
And if you're using a Kelly sponge, what you can do is just go in your corneal incision and then come out, so that you can just see the opening of the sclerostomy. And the sclerostomy, the distance between the sclerostomy and the edge of your scleral flap has to be around between 0.5 to 1 mm. That's the ideal sclerostomy. Works very well.
Yeah,
I
2
think
minutes does the job.
that's all, ma'am. From the YouTube channel, we have these many questions.
Great. So if you don't have any other questions, I think we can close the session now. Thank you so much, ma'am, for this exhaustive. We have, I think, gone past the time, but it doesn't feel like we have taken 1 hour, 15 minutes. We can go on and discuss so many more things. But yeah, this is what our time is permitting us. So thank you so much, ma'am. Thank you for this very informative and very helpful lecture. I've learned a lot, and I hope people who see this video also learn. And thank you, our chairperson, Kamaljit sir, again for giving so much of your valuable time and supporting iFocus. Thank you, Dr. Kanika and Dr. Ishita, for all your support.
Thank you very much. Grateful to all of you. Thank you, sir.
Thank you all. You all know that Dr. Kanika is with me today with Cataract. So I'm learning so much from her, from the young ophthalmologist. So thanks everyone and thanks ma'am. Thank you so much.
Thank you and good night.
Good night.
Thank you, ma'am. Thank you, sir.